Hi, this is Dr. Akhtar Amin. Today's topic is non-allergic eosinophilic conjunctivitis, contact allergic blephariconjunctivitis, giant papillary conjunctivitis, conjunctivitis in blistering mucocutaneous disease in which there is mucous membrane pemphigoid and Steven-Johnson syndrome. So first one is non-allergic eosinophilic conjunctivitis. It is a recently proposed condition. It is a chronic and non-atopic and occurs in middle-aged women in which already there is dry eyes. So it has been suggested that it is relatively common, but it is underdiagnosed and is thought to be of similar pathogenesis to non-allergic eosinophilic rhinitis. There is conjunctival eosinophilia. There is a it is without significant IgE levels in the serum arterial film. The symptoms are similar to those of allergy. There is itching, redness, foreign body sensation, watery discharge, and the treatment is topical steroids and mast cell stabilizers, NSAIDs, antihistamines. Next is after non-allergic conjunctivitis, now contact allergic blephariconjunctivitis. So it is analogous to contact dermatitis, and it is acute or subacute T cell mediated delayed hypersensitivity reaction. Most commonly, it is a reaction to eye drop and a reaction to contact lens solutions. And a less common cause is mascara. There may be a conjunctival reaction, but signs predominantly involve the eyelid skin. There is erythema, thickening, induration, fissuring, and treatment is discontinuation, the precipitant, and a mild topical steroid is also helpful. So this was contact allergic blephariconjunctivitis. Now giant mechanical induced papillary conjunctivitis. Mechanical induced it is a severe form which is known as giant papillary conjunctivitis. The GPC occurs secondary to a lot of mechanical stimuli. Mechanical stimuli of the tarsal conjunctiva. The mechanical stimuli are the contact lens wear. So then it is known as contact lens associated papillary conjunctivitis. The risk is increased by buildup proteinaceous deposits and cellular debris on the contact lens surface. The ocular prosthesis is another mechanical stimulus. Exposed sutures, scleral buckles, corneal surface irregularity, filtering blips. So these are all responsible. Another phenomenon is mucus fishing syndrome. These underlying anterior segment disorders. The patients develop or exacerbate a chronic papillary reaction due to repetitive manual removal of mucus fishing syndrome. Giant papillae can also be seen in other conditions such as VKC and AKC. Now the diagnosis of giant papillary conjunctivitis. There is foreign body sensation, redness, itching, increased mucus production, blurring, loss of contact lens tolerance. And patients should be questioned about contact lens cleaning and maintenance. The sign there is mucosal discharge, contact lens protein deposits, contact lens mobility, superior tarsal hyperemia and papillae. Giant papillae are more than 1 mm diameter, and there is fine medium papillae, particularly in early mild disease. There is focal apical ulceration, whitish scarring on large papillae. Keratopathy is rare. And ptosis may occur mainly as a result of irritative spasm and tissue laxity, which is secondary to chronic inflammation. Now treatment. First of all, exclude other causes of conjunctival papillae as well as contact lens intolerance due to other causes such as the reaction to the lens cleaning solution, dry eyes. So the first treatment is removal of the stimulus. So first of all, contact lens wear should be discontinued for several weeks and the current lens is replaced. If there is mild to moderate disease, this may be adequate for resolution. Sometimes in conjunction with reduced wear in time. If there is severe CLPC, then a longer interval without lens wear may be needed. Next, removal of other underlying causes such as exposed sutures, such as scleral buckle. Also, assessment of the status and fit of ocular prosthesis. Filtering blade, partial excision, revision with non-penetrating drainage surgery, glaucoma drainage device. Second treatment is ensure effective contact lens cleaning or prosthesis and change the type of contact lens solution, discontinue preservative containing preparations, switch to monthly and then daily disposable contact lens if the condition persists after renewing non-disposable lenses. Rigid lenses carry a reduced risk of CLPC, which is 5% risk, because they are easier to clean effectively. So rigid lenses are good. And cessation of contact lens wear, substitute it with spectacles or refractive surgery if there is severe disease. Regular, at least weekly use of CL protein removal tablets. Polishing, cleaning of prosthesis with detergent and coating. The topical treatment are mast cell stabilizers and non-preserved in patients wearing soft contact lens. And can be installed with lenses are not in the eye, where a delay of perhaps half an hour after drop installation prior to lens insertion. Most can be continued long term if necessary. And there is antihistamines and NSAIDs and combined antihistamines, mast cell stabilizers, topical steroids for acute phase of resistant cases. Those where effective removal of the stimulus is difficult and bleb related tissue. Oh, this was all about giant papillary conjunctivitis, mechanically induced papillary conjunctivitis. Next topic is conjunctivitis in blistering mucocutaneous disease, in which the first one is mucous membrane pemphigoid, also known as MMP, also known as ocular cicatricial pemphigoid, OCP. It is a group of autoimmune mucocutaneous blistering diseases, and there is unknown trigger, and there is type 2 hypersensitivity response, and antibodies bind to the basement membrane zone, and there is activation of complement, recruitment of inflammatory cells. There is localized separation of the epidermis from the dermis at the basement membrane zone, and then there is progression to scarring, and there is increased susceptibility with HLA-DR4, HLA-DQB1. There is strong association with OCP and other forms of pemphigoid disease. So a wide range of epithelial tissues can be involved, including the skin and various mucous membranes. So the skin can be involved and mucous membranes. Particular clinical forms of MMP involve the specific target tissues, and there is bullous pemphigoid for skin and ocular mucous membrane. Ocular cicatricial pemphigoid involves the conjunctiva in the majority of cases, and which leads to scarring. It occurs in old age, affects females with a ratio of 2:1. Other causes of cicatrization include Steven-Johnson syndrome, trachoma, drug-induced trauma, trauma and severe chronic conjunctivitis. So MMP should not be confused with pemphigus, which is a distinct group of disorders. Now the ocular features. The ocular features diagnosis is principally clinical, but biopsy of involved mucous membrane often shows supportive changes in which there is linear antibody and complement BMZ deposition. The progression has been divided into stages, and there is Foster classification. Foster classification, there are 4 stages. In first stage, there is a early stage with chronic conjunctivitis, there is tear dysfunction, and there is subsequent fibrosis. In stage 2, there is fornical shortening, especially inferiorly. Stage 3, there is semblepron, and in stage 4, there is surface keratinization and cicatricial ankyloblepron. Now the symptoms, there is they may be insidious or relapsing remitting. There is bilateral conjunctivitis, misdiagnosis dry eye. In conjunctiva, there are specific signs such as papillary conjunctivitis, diffuse hyperemia, edema and subtle fibrosis. There is fine lines of subconjunctival fibrosis, shortening of the inferior fornices, semblepron, the plural is semblepra. Semblepron formation refers to adhesion between the bulbar and palpebral conjunctiva. There is necrosis in severe cases. There is flattening of plica and keratinization of caruncle. The dry eye due to destruction. Dry eyes is due to destruction of the goblet cells and accessory lacrimal glands and occlusion of the main lacrimal gland. So monitoring should include measurement of fornical depth and noting the position of adhesions. So here you can see fornical shortening and semblepron formation. So this is the sign in conjunctiva. The eyelids, there is aberrant tracheitic lashes. Aberrant lashes known as tracheitic lashes. Chronic blepharitis, there is keratinization of the lid margin. There is ankyloblepron, which is the adhesion at the outer canthus between the upper and lower lids. Here you can see ankyloblepron. Here is flat plica and keratinized caruncle. Now the cornea, there are epithelial defects due to drying and exposure, infiltration, peripheral vascularization, and here you can see peripheral vascularization and infiltration. There is keratinization, conjunctivalization of the corneal surface due to epithelial stem cell failure. Here you can see keratinization with ankyloblepron. End-stage disease characterized by total semblepron, corneal ossification. Systemic features, mucosal involvement is very common. There is subepidermal blisters, most frequently oral blisters. Severe manifestation, there is esophageal laryngeal stricture. And skin, less common lesions, about 25% cases. Tense blisters and erosions in the head and neck, groin and extremities. Now the systemic treatment. It is the main step management. Any detectable inflammatory activity should be suppressed. Dapsone is a diamino diphenyl sulfone. It is the first line treatment in patients with mild to moderate disease. 70% of patients respond favorably. Contraindicated in G6PD deficiency, sulfasalazine is better tolerated. Anti-metabolite like azathioprine, methotrexate, cyclopain, fentolate, mofetil, they are alternatives for mild to moderate disease if dapsone is contraindicated, if dapsone is ineffective, dapsone is poorly tolerated, and suitable for long-term therapy, Dipsone can be used in conjunction if necessary. Cyclophosphamide may be reserved for severe refractive disease. Next, steroids. Prednisolone 1 to 1.5 mg per kg are effective for rapid disease control, but adverse effects limit long-term use. IUP should be monitored. Other measures include intravenous immunoglobulin therapy, rituximab, and remission has been reported with a combination regimen. Now the local treatment. It consists of topical artificial tears, preservative-free, topical steroids, cyclosporine, tacrolimus, in adjunct to systemic immunosuppressive treatment. Retinoic acid to reduce keratinization, antibiotics, lid hygiene, low-dose oral tetracycline for blepharitis. Subconj mitomycin steroid injection may be used temporizing aid, and if systemic immunosuppression is not possible. Contact lens may be used with caution to protect the cornea from aberrant lashes and from dehydration. Reconstructive surgery under systemic steroid cover when active disease control for aberrant eyelashes, punctal occlusion, lateral torsorrhapy, botulinum toxin induced ptosis, entropion repair, conjunctival excision is avoided. Cataract surgery, mucous membrane autograft, AMT for conjunctival resurfacing, for corneal restoration. Limbal stem cell transfer for corneal reepithelialization. Keratoplasty, there is high risk of failure. Laminar grafts may be effective for perforation. Keratoprosthesis may be the only option in end-stage disease. Here you can see keratoprosthesis. So this was all about the mucous membrane pemphigoid, also known as ocular cicatricial pemphigoid, which was type 2 hypersensitivity response. Now the next important disease is Stevens-Johnson syndrome, also known as toxic epidermal necrolysis or Lyell syndrome, also known as erythema. The Stevens-Johnson syndrome and erythema multiforme measure. Historically, they were used synonymously, but now it is believed that erythema multiforme is a distinct disease, milder, recurrent, and there are dissimilar clinical features. Toxic epidermal necrolysis, severe variant of Stevens-Johnson syndrome, tends to occur in young adults. There is cell-mediated delayed hypersensitivity reaction. It is related to drug exposure, and drugs include antibiotics like sulfonamides, trimethoprim, analgesics like paracetamol, and nevirapine, which is for HIV infection, nevirapine, cold remedies, anticonvulsants, infections due to mycoplasma pneumonia, HSV, cancers, and symptoms often take weeks to develop. So many cases the precipitant cannot be identified. Mortality 5% in Stevens-Johnson. Death is due to infection. This is considerably higher in TEN, toxic epidermal necrolysis. Now the ocular features. In the acute stage, there are often practical obstacles to standard slit lamp examination, as the patient may be bedridden, may undergo barrier nursing, so a portable slit lamp may be helpful. There is symptoms are redness, acute redness, mild severe grittiness, photophobia, watering, blurring. In the acute signs, there is hemorrhagic crusting. Hemorrhagic crusting of the lid margins. Here you can see it is characteristic. The skin lesions may be confluent. It is often difficult for an examiner to open the eyes without causing discomfort. Papillary conjunctivitis, from mild, transient, and self-limiting to severe. Conjunctival membranes and pseudomembranes. Severe hyperemia, hemorrhages, blisters, and patchy infarction. Keratopathy is a spectrum of lesions from punctate erosions to large epithelial defects, secondary bacterial keratitis, and occasionally perforation. Iritis is not infrequent. Panophthalmitis has been reported. Now the late signs there is conjunctival scarring, conjunctival cicatrization, pharyngeal shortening, symblepharon formation, keratinization of conjunctiva, keratinization of lid margins, abrasive plaque formation. Here is keratinization with severe lid involvement. Eyelid complications, there are cicatricial entropion, ectropion, trichiasis, metaplastic lashes, ankyloblephron. Keratopathy includes scarring, vascularization, and keratinization as a result of primary inflammation or infection, as well as cicatricial entropion, aberrant lashes. Watery eyes are due to fibrosis of the lacrimal puncta. Dry eyes may also occur as a result of fibrosis of the lacrimal grand ductules, conjunctival metaplasia with loss of goblet cells. Now the systemic features, the skin biopsy is helpful to establish the diagnosis but rarely necessary. What are the symptoms? There are flu-like, it can be severe, may last for 14 days before appearance of lesions. Patient is very ill, hospitalization is required. There is systemic mucosal involvement, nasal pain, discharge, pain on micturition, diarrhea, cough, shortness of breath, pain on eating and drinking. The signs are mucosal involvement, there is blistering, hemorrhagic crusting of the lips, it involve the tongue, oropharynx, nasal mucosa, genitalia. There are small purpuric, vesicular, hemorrhagic, necrotic skin lesions involving the extremities, face, trunk, usually transient but may be widespread. Healing usually occurs within 4 weeks. There is leaving a pigmented scar. Widespread slapping of the epidermis is uncommon. Target lesions show classic 3-zone or now VUS characteristics of Rhythema multiforme rather than Steven Johnson. Now the systemic treatment. First of all, the removal of the precipitant such as discontinuation of the drugs. Treatment of the suspected infection. The general measures are maintenance of hydration, electrolyte balance, nutrition, protein replacement, specialist blood unit will reduce the chance of infection. Systemic steroids, they are controversial. They increase mortality in older papers, but later research has raised possibility that early short-term high-dose intravenous treatment may improve outcome. Other immunosuppressants such as cyclosporine, azathioprine, cyclophosphamide, intravenous immunoglobulins may be considered in select cases but are controversial and controlled trials are lacking. Systemic antibiotics may be given as prophylaxis against skin, other systemic infection, avoiding those known to be higher risk of SJS. Now the ocular treatment. In acute disease, daily review is advisable in most patients to check cornea, exclude symblepharon. So the treatment consists of topical lubricants as frequently as possible. Prevention of corneal exposure by moisture chamber, gel pads, topical steroids for arthritis and inflammation, topical cycloplegia, lysis of developing symblepharon with a sterile glass rod, lamp, cotton bud. Scleral ring consists of large heptic lens, may help to prevent symblepharon formation. Pseudomembranes, membrane peeling, treatment of corneal problems, conjunctival swabs, IUP monitoring by portable tonometer. Now chronic disease. Chronic disease, adequate lubrication, punctal occlusion, topical trans-retinoic acid 0.01 to 0.025% to reverse keratinization, treatment of aberrant lashes, bandage contact lens, gas permeable scleral lenses to maintain surface moisture, protect cornea from aberrant lashes, and arrest irregular astigmatism. Mucous membrane grafting, for example, buccal mucus autograft for pharyngeal reconstruction. Corneal rehabilitation involves superficial keratectomy. For keratinization, lamellar corneal grafting for superficial scarring. The preferred is penetrating keratoplasty. AMT, limbal stem cell transplantation, keratoprosthesis in end-stage diseases. Thanks a lot.